fast, but so the way that I like to do things is that if there's something that you don't understand or something you want me to re-go over, feel free to let me know. So once again, I graduated, OCU wasn't there because I'm old, so we didn't have the PA school, so I'm from OU days. I graduated in 2001, so in November I'll be out 17 years. I never have done anything besides orthopedics. They always say, oh, go into primary care and do that and get your foundation down, and I just kind of went, oh, okay, that sounds good. I just went straight on to orthopedics, which once again, I don't know that I'd recommend that, but that's what I did, and I still turned out fine. So, so I do work at Olson Orthopedics. We do surgery at the Bone and Joint Hospital in the hospital, or One Core Hospital. That's my email, so in case anybody wants to, you know, harass or ask questions, feel free. So we'll go through this pretty good here. So orthopedic based treatment. So the hard thing is you guys are now how far into your 12 months of didactic work? 7 months. So you guys know kind of the common sense stuff, right? As far as, well, I assume you do. But like whenever I say NSAIDs, you know what NSAIDs are, right? I mean, I don't need to spell all that out. So once again, anti-inflammatory. So this is just basic treatment. So the anti-inflammatory is the RICE protocol. Icing 20 minutes on, 30 minutes off. We usually tell our patients icing only for the first 24 to 48 hours, and then after that, if you want to do the heat in the ice or the contrast baths or whatever you want to do, that's fine with me. Activity restriction, rest and mobilization. This is obviously going to be specific for each, thank you, mood light. For each injury, okay? So like we're going to treat somebody who sprains their ankle different than somebody who we just did a total knee replacement on, right? So physical therapy, occupational therapy, highly underused for minor injuries. People gripe and gripe and gripe about having to go to formal physical therapy and put ice on themselves. Whenever those are two of the things that could really be the difference in them having to either spend more money on MRIs or also even possible surgery. More effective in pain control in the long run. So basically whenever we have people, and I'll go ahead and tell you guys this now, I make orthopedics very, very, very simple because sometimes, you know the old saying, you have to know your audience. So I try to make it to where everybody, whether you're a college professor or you are 2 years old, you should be able to understand our treatment process. So I tell every single person who walks through the door, and I'll tell you why this is important. I say you've got 5 options, and I don't care what's wrong with you, you have 5 options. You can do nothing about it and see if it goes away. You can do icing, anti-inflammatories, and therapy. We can go get an MRI if whatever's wrong. We can inject whatever's wrong, or we can do surgery on whatever's wrong. So if you think about it that way, and so I encourage you to treat your patients with this. At our clinic, I do not wear a white coat. I haven't worn a white coat in 10 years. I don't stand up whenever I talk to our patients. I sit down at the same level of them, or sometimes I even sit on the floor if it's been cleaned recently. But the thing about it is people don't like it whenever you try to talk over their head. If you ever read a spine MRI to somebody, I don't even know what all the words mean all the time. And you know, if you start talking fast and you start talking and using big words, you're going to lose them every single time. So whatever I always try to do is I say, look, this is a team approach. It's Dr. Olson who's my supervising physician. It's myself and it's you. So we're all going to be in this together. That's why I call them your 5 options, because I'm not going to go in the room and tell somebody what to do, because I don't really like being told what to do. So I'm going to go in and say, look, these are your 5 options. Let's talk through them. Which one do you think fits you best? Which one do you start off with first? And when you let them be involved in their own health care, man, that's huge, because people go, oh, hey, he cares what I think, instead of just walking in and going, how many of you have been to the doctor when they just walk in and go, here's what you're going to do? Right? Everybody. Here's the medicine you're going to take. Here's what you're going to do. But if you ask me my opinion on it, oh man, thanks, that's kind of cool. And also, it protects you on the back run, because, and this has actually happened to me before in my earlier years, if I say, hey, I think you've torn your ACL, you need to go get an MRI, and somebody may be a little bit financially strapped for cash, they go spend, I don't know whatever their deductible is on an MRI, $1,200 if it's out of pocket, and it comes back normal. Well, you told me you'll get an MRI. My ACL's not even torn. You were wrong, and I had to spend all this money. Well, guess what? If I let you pick what you want to do, and you said you want to go get an MRI, you're the one that spent that $1,200. So it lets them be involved, but it also kind of lets there be a sense of, hey, we're all in this together, instead of me telling them what to do with all these expensive treatments. All right, so fracture description, everybody feels comfortable with the different parts of the bone, the epiphysis, the metaphysis, the physis, the diaphysis. Everybody's good with all of that stuff, right? Okay, good. And really this doesn't come into play that much unless you're like me, and back when we used to take call from emergency rooms, and you've got somebody trying to describe to you what type of a fracture something is or where it is. And I'll get to that here in a second on the next slide, but basically this is just the parts of the bone. Fracture description. So complete versus incomplete. Incomplete obviously means it doesn't go all the way through all of the cortices. You'll hear them called everything: cracked, hairline, buccal, green stick, torus, different things like that. So these are the most common types. Obviously the normal bone, transverse fracture, oblique. You can have a short oblique or a long oblique. Spiral is like if you twisted it. A comminuted, of course, means in multiple pieces, and segmental means in more than one fracture. Lots of people like to still use the word compound. Compound is the same thing as an open fracture. If it is compounded, it means it's open. So don't use compound. Use it as either closed and the skin is not broken, or it's open and the skin has been compromised. Everybody cool on that? Any questions about this slide? Okay. Fracture description, once again, relationship of the fracture segment. So remember, you always describe what the distal piece is doing. So if I break my distal radius and the distal piece is volarly angulated, well, I'm going to describe that as a volarly angulated fracture, right? So it's whatever the distal piece away from your body is doing. So once again, non-displaced versus displaced. The displaced can be angulated, translated, rotated, distracted, shortened, or overriding. We'll show you some of those whenever we get to a couple of pictures here. Relationship to the external environment, once again, closed versus open. Okay. So everybody's good with Salter Harris's, I hope by now. Okay, so, and actually these are pretty rare. I mean, I shouldn't say that. 5s are super rare. I saw 1 4 last week, and I haven't seen a 4 in probably 2 or 3 years. You'll see a lot of 3s and a lot of 2s, and actually a lot of times on the 1s. Let me give you a hint about 1s. If somebody comes to you and they are seeing their primary care physician, they shot an x-ray, the x-ray didn't show anything, and so the way that we do it is if you have tenderness to percussion over a bony growth plate, so like let's say that they think you may have twisted your ankle, and I take your ankle or your medial or lateral malleolus and I simply tap on it like that, and that little kid comes unwound, it's a fracture until proven otherwise, because you can't see the type 1s on an x-ray. Now you'll have some people who get all fancy and think they can, but they can't because there's nothing displaced. The only way you can find that is if you get an MRI or a CAT scan. So once again, if you have somebody that comes to you for a sprained anything and they're an athlete and they had an injury that would justify a possible fracture, I want you to tap on that bone or press really hard on it. They feel like a jerk doing it, but you got to find out, because it is the difference in treating it like a sprain and putting it in a brace, or treating it like a fracture and putting it into a walker boot. Everybody good with those? Yes? Okay. All right, so shoulder. So first of all, glenohumeral dislocations. 95% of all shoulder dislocations are anterior in nature, with 5% being posterior. Axillary nerve is the most common. So if I have an injury to, let's say I come in your emergency room and I said, my shoulder's hanging out like this, and I was like, hey, this isn't what it's supposed to be. And you want to test my axillary nerve, what are you going to try? You're going to touch it, right? If it's numb and tingly, you got to worry about it a little bit. That is, once again, one of those things I think that's very good to know from a common sense and practical standpoint. From a book standpoint, doesn't really come into that play that much with us, but once again, by the time they get to us, since we're kind of super specialized, they've already been reduced 9 times out of 10. We don't see them in the emergency room. Most commonly caused by a fall on an abducted, externally rotated shoulder. So you've got the people who are kind of landing like Superman or going out for a pass or something like that. Also, they can happen really easy. We have quite a few, not pitchers, but quarterbacks who are going to throw like this and then they get tackled and it goes back even further. That's why when we get to the apprehension test, that's why that makes that hurt. So there's 3 reasons why you will have a posterior dislocation of a shoulder: alcohol, epilepsy, and electricity. So if they get electrocuted, it will probably go out the backside, or that would be a reason for it. Same thing with alcohol; they're so relaxed it can do that, and then obviously seizures can do that. We had a kid that had seizures, and every time he woke up, both of his shoulders were dislocated posteriorly. Like every morning, it was like Groundhog Day. So he also had a bad case of ligamentous laxity. So that, once again, that's kind of a cool fun fact, but other than that, those are why they come out the back. Now remember, that's also opposite of your hip. Hip always goes out the back, rarely anteriorly. But we're not talking about the hip today. All right, so shoulder glenohumeral dislocation, examination, slightly abducted and externally rotated. You have the loss of this appearance. I don't think this thing has a pointer or anything. Oh, it does, yeah. You guys are fancy parents. So see how his shoulder is rounded right here? Because it's up in the joint, his deltoid looks normal. See how here, how it goes, and there's that dislocation. So there's the undersurface of his acromion, because his humeral head is sitting about right there, okay? So that's the difference. So you can see it. It is literally dropped down. Remember that most of them come down and out the front and down. Resistant movement because it's going to hurt. So you're going to say, hey, let me take a look at your shoulder. And they're going to go, no, not really. I don't want you to do that. Radiology 3 views of the x-ray of the shoulder with the axillary Y or the scapular, or excuse me, axillary to the scapular Y. Scapular Y is, I will show you right there. So as everybody can see, so this is your scapula, obviously, and there's your acromion collarbone, and it makes this Y right there, right? And as long as the humeral head is in the middle of that, that is normal. If it is sitting in the front, it's an anterior dislocation, posterior, it's posterior dislocation. That is, and now it's hard to tell, but remember the x-rays, you're taking something that is three-dimensional and making it two-dimensional, right? Because you're flattening it. So anytime something is on top of something, it's going to be whiter, right? So now this one, I've never seen a posterior shoulder dislocation behind the scapula, but I'm just saying in theory, that's why they want you to get more than one view, because in theory this could be argued whether it be in front or behind the scapula. Of course, we all know it's anterior because we know it's anterior. And you'll be able to examine the patient. This one is super far down. I mean, that one's almost at breast level, almost right there. Where were we at there? Associated injuries. So once again, let's go back to one. I don't think we have one on here. But an axillary view is if you have them laying down. And so remember, you've got somebody who more than likely, if they're seeing you, it's their first time dislocation. First time dislocators, if you have people who say, it's my first time dislocating my shoulder and I put it back in myself, I would not believe them. Most first time dislocators freak out because what happens is your shoulder dislocates, your body says, I don't think that's normal, what should I do? And so then all of your muscles spasm up, so it will actually catch the humeral head on that head of that glenoid. Remember your glenoid, that part of the scapula is a flat plate. It's almost like a dish almost. So it gets stuck like that. So what you have is you have your shoulder muscles all trying so hard to pull it back in. So if you have somebody that does the whole Mel Gibson, you guys are probably too young, but anybody see Lethal Weapon? With Mel Gibson, when he hits his shoulder against the pole. So if you think about it, if your humeral head is perched on the anterior aspect of your shoulder or of your glenoid, and then you're banging it backwards, that's probably not going to work out so well, and it doesn't work like that, except for on Mel Gibson. I mean, it's Mel Gibson, right? So the associated deformities. So now let's talk about this, the Hill-Sachs deformity. So imagine this: if you have a humerus with the articular cartilage on it, and it catches on that glenoid rim, it's going to make a dent. You know when you go to some parties, I'm assuming, that you have styrofoam cups and everybody uses their fingernails to write their names in it? That's what a Hill-Sachs deformity looks like. It is literally a little dent in that articular cartilage, and it's usually a straight up and down line or almost like a scuffing of it. So if you think about it, whenever you dislocate your shoulder, the shoulder comes out, body says, oh no, brings it back, and then sometimes it'll go ahead and come back in, but very rarely. A labral, or excuse me, a Bankart lesion is a labral tear. So you can either have a Bankart lesion where the labral tears off of the bone. You guys are familiar with anatomy, right? Labral tears. And then you can also have a bony Bankart, and that's where instead of the labrum removing itself from the glenoid actually breaks with it. So there's a piece of bone that travels with the labral tear. Treatment, closed reduction through manipulation of the humeral head. Remember to get post-reduction x-rays. You have to prove it was back in before they leave the emergency room, before they leave the office. It's just good medicine. Sling and immobilization with physical therapy, occupational therapy, and operative recurrent chronic. So, reduction techniques. I will tell you, you can learn all of these stuff in these things, and the first time you try to do it, the pucker factor is going to be high with that one, because you're going, oh my gosh, never got it done. And you have to remember, especially because the last one we had, it was almost this bodybuilder guy, you have to fatigue their shoulder to get it back in. Now, if it's like I used to cover the UCO hockey team, and we had a goalie that his shoulder would come out probably, I don't know, 1 or 2 times every other game. And on him, I could just raise his arm up in the air and they go, boom, and you go, hey man, thanks, and he'd skate back off and go start doing his stuff. But if it's a first-time dislocation, you have to remember their body is mad at the current situation they're in, so it's not going to let you do anything. So you can either do one of 2 things. If you're in and you feel comfortable with this, I'm not saying do this in primary care if you don't feel comfortable, But if you're in the orthopedic setting or emergency room setting or something like that, and you have availability to it, you can get 20 cc's, you don't have to write this down, but this is kind of cool, 20 cc's of 1% lidocaine and literally flood their glenohumeral joint. I mean, fill that sucker up, and what it'll do is, it'll numb the capsule, their body will go, hey, I know that this isn't cool, but I'm feeling all right, and they'll relax. And as soon as they relax, it'll go right back in. You barely even have to try, right back in. But if you don't have that, and you are on the sideline, or you are out in rural Oklahoma, and there's a lidocaine shortage, there are other things you can do. Snowbird or a snowmass technique. A snowbird technique. Can I have a volunteer, please? Can you guys still see with the mood lighting on here? Come on. Don't be shy. Right here. Okay, so sit with your legs facing them underneath the handle and hang your arm off the side. So this is called a snowbird technique or a snowmass. I think it's actually the place where they had the original conference. If this wasn't so big and it was a normal chair, her arm wouldn't be like that. So what you do is you put a TheraBand or some stockinette like you put on when you put a cast on, and you loop it around her arm. And so what we do is you literally put your foot up in it, and so you put downward traction like that. You have an assistant standing over there that wraps their arms around their body. So the assistant's pulling her that way, and I'm pulling downward traction on her arm, and it will sometimes go back in. Because remember, you're trying to get that humeral head off of that lip of that glenoid. It's stuck there. It wants to live there now. You've got to get it off of there. Thank you. That was very good. All right, enough. Give her applause. So Stenson is the Stenson technique. Is where you have someone lay. Has anybody ever had a dislocated shoulder before and had to have it reduced? What'd they do to you?
Shoved it back in.
You shoved it back in?
Somebody on the sidelines did.
Very nice. So very barbaric, but very nice. So a Stenson technique is I'm not going to lay on this because I don't know if it'll hold me. But basically you have the patient lay on their stomach, their arm hangs off the side of the bed, and you put 10 pounds of traction on it. And then I'll go see a patient. And then I'll come back and I'll put 5 more pounds on it. And then I'll go see a patient. And then I'll come back and I'll put another 5 pounds on it. So now we're at 20 pounds. Because remember what I said before, we're trying to fatigue the deltoid. The deltoid. The deltoids are big muscles. That's what's still fighting you at this point. So if you can fatigue the deltoid, then it will just come right back in. So they've been hanging there, their shoulders tired, they're tired of fighting it. Even if they've been trying their hardest, they're tired of fighting it. And you just take it down, put a little bit of traction on it, slide it right back up in. I don't know why I put bed sheet there. Actually, I didn't type this out, but that's incorrect. Counter traction, that is the bed sheet. You have them laying on the bed, you wrap a bed sheet around them this way, you pull traction on it this way, your helper pulls traction on it that way, so you're basically just pulling them apart. The coolest one that I've seen to do in the field, and it's called I wrote it down because I always forget the name of it. There's 2 more. Coker and Spazo technique. I don't know why I can remember that. A Spazo technique. So if you're in the forest hunting, or if you're literally on the sideline like Chief was, if I'm laying down on my back, so let's pretend that I'm the injured player and I'm laying down on my back, my shoulder is anterior and inferiorly dislocated. So the Spazo technique is you take their arm and you pull it up to about 9 degrees of forward flexion. And forward flexion, or once you get to 90 degrees, you're going to maximally external rotate the shoulder, and then you're going to internal rotate it back in and let it back down. Now, when you're doing all of this, you've got your foot in their armpit. There's the counter traction. So if you see all of these techniques, there's always a traction, right? You have to fatigue the deltoid. So if I have someone's arm, I've got them forward flexed at 90 degrees, completely externally rotated, I put my arm or my foot right in their armpit, and I pull traction on it, and then I gradually internally rotate them, and that will come back down in, usually. So whatever you have to do to get back in. If you can't get it back in, don't keep trying. I mean, if you're in the emergency room and they're grossly not, or let's see that they're not neurovascular intact, keep trying. But until then, like if you don't feel comfortable, don't mess up other stuff just to say, hey, I got my first shoulder back in. But once again, if it's their first time, it's going to be a lot tougher than if it's their 5th or 6th. This is called a coker. So the coker is basically they're laying on their back. This one's probably the one that's going to be in your textbook. This one's been around for, literally they have pictures of this on the Egyptian hieroglyphics. They say it's been around for like 3,000 years. So that's not a joke. I mean, I'm dead serious. So what they do is you have them laying on their back, you have them external rotate them. As soon as they meet resistance, you start flexing them back up, and then once again, rolling it back down in. And that's where this all means. All right, that's a Stenson. I'm sorry, that's not Stenson. That's the counter traction technique. So somebody's pulling, we call it water skiing because you don't want to jerk. So you know when you're water skiing, you just kind of lean back. So don't yank on them, just lean back on them, okay? All right, so that was a lot about that. Once again, for something you may or may not ever have to do, but it's kind of cool when you think about it. AC joint injuries, acromioclavicular joint involving the coracoacromial and, acromioclavicular and coracoclavicular ligaments, type 1 through 6 sprains. Now, so if you see it, this is kind of like the whole Salter-Harris 1. A normal x-ray, an AP x-ray, will show a type 1 AC separation is normal because there's no elevation. What you're looking for whenever you look for these things and the way that you categorize it is you look at the bottom of the acromion and you look at the bottom of the clavicle. If those two things are equal, it is a type 1. If the bottom of the clavicle is 50% elevated on the acromion, it's a type 2. If it's 100%, meaning it's completely over, it's a type 3. Type 4 means it goes back behind. I've actually never seen one of those, but it actually goes back and gets stuck back behind the acromion. Type 5, it looks like a ski jump. That thing, they're going to come in, you're going to go, what in the heck is that? It's like this. It's up super, super high. And type 6 is, once again, never seen it. It actually gets hooked underneath the biceps tendon, or between the coracoid and your acromion. Or, I'm sorry, above the coracoid and the biceps tendon. So once again, most common ones, 1, 2, and 3. Anybody watch OU football? Okay, remember when Sam Bradford hurt his shoulder against Texas and everybody's going, oh my gosh, Sam Bradford's hurt, should he have surgery or not? He's going to go to the pros. He had a type 3, and they were arguing that much over it. So once again, type 1, you don't do anything with it. Type 2, you don't do anything with it except for put him in a sling. Type 3, if you're Sam Bradford, everybody's going to make a big deal of it, but in you and I, we're not going to do anything about it. It's 4, 5, and 6 that we're going to do something about. The only time we do anything with 3 is if it starts messing with your everyday activities. If I can't do my job, and we can actually bring that back down and repair it. So type 1 and 2, leave them alone. Type 3, everybody needs to have a big talk about it. 4, 5, and 6, honest to God, I can't tell you the last time I've seen one. This AC shear, try saying that fast. AC shear test. I don't know, that's a book one, I don't do that one. The best one you can do to figure out if something's hurting or not, touch it, right? If it's dislocated or separated, you can just push right there and they'll go, oh man, that hurts. Another thing you can do is have them just simply do this stretch right here. And remember, anytime you bring your arm across your body like that, it's going to pinch that AC joint. If it's separated or injured, it's going to hurt really bad. So it's called the cross-body adduction test. Am I going too fast? You guys good? Okay, I feel like you're going too slow. We're ready to go home. All right, so radiology, x-ray of the shoulder. Zenka view allows the AC joint to be seen without overlapping images. So basically, instead of shooting straight on with my shoulder like this, they kind of angle up underneath it. So that way, sometimes the people, the radiologist tech, sometimes if they're in a hurry and ready to go home, sometimes they'll overlap it. They'll either be coming down too high or too low. So this one kind of shoots it right at this perfect angle. I don't ever ask for that. So once again, type 1 through 3, treated conservatively with immobilization and physical therapy. 4, 5, and 6, you got to get those fixed. That kind of rhymes, actually. Also, the way people always come in and they say, okay, what do you do with the type 1 through 3? So we'll put them in a sling. Once they get a little bit better, we'll start them moving, either at home or in therapy. And so whenever I have somebody that's like, let's say a football player comes in, and he wants to know, when can I go back and play? Once you can do a push-up, you can go back and play. That's what we do. Because if you think about it, if you bring your arm across your body, that hurts. It collapses that joint, right? So if you're doing push-ups, all of the pressure is going to be on that. So if somebody can do a bunch of push-ups and not have any pain, that's when we allow them to gradually increase their activities. That's another thing that I would highly recommend that you guys remember to say if you're going to go into orthopedics, because when people say, when can I do whatever I want to do, when you can do so with, in regards to comfort, confidence, and safety. Comfort means if it hurts, don't do it. That's pretty much easy. Everybody gets that concept. Confidence means if I just had this and then somebody asked me to go be in a powerlifting contest tomorrow, I'm not going to have a lot of confidence that I want to do that, right? And then obviously safety is if it's not going to be safe. That's more of a word comp thing. Proximal humerus fractures occur most commonly in the elderly and majorly treated non-operatively. This is the one where you have to educate the family because some of these things look like they came out of aliens. They fell off their bed, or mostly off the stool, or out of their little buggy that gets them around Walmart. But I mean, it happens a lot, and they will look terrible. But believe it or not, they heal beautifully most of the time with non-operative treatment. Even if they dislocated and were relocated and still have the fracture, they still good without surgery, usually just depending on where it is. Examination, of course, they're going to have swelling, tenderness, palpation, pain with range of motion. These people aren't going to let you touch them. They're just going to, like, as soon as you start to reach for them, they're going to clam up and won't let you do anything. Once again, loss of deltoid sensation. That's one of those things that needs to be part of your everyday dictation. That is almost like saying, you know, whatever-year-old female, I mean, as soon as you say something, I would make sure that you say they can feel their deltoid. Because if not, I mean, you'll get it when you get out, but there's a bunch of stuff that people look for that you can mess up on. Radiology, 2 views of the humerus or 3 views of the shoulder. Remember, these people have a broken humerus. They're not going to want you to move it around very much. That's why I don't take the x-rays when we make other people do them. NIRS classification based on segments of the humerus. So basically, it's kind of like the rule I told you about the distal segment. That's what you say, whether it's volar or distal or translated or whatever. So classifications of a humerus fracture are in parts. So if I was going to show you this one, how many parts would you say that one's in? 2 parts. Hang on, is this a fracture? Are you sure? So that's a growth plate, right? So it's a kid. Now, what if this was intact and we saw that and you tapped on it and it hurt? What would it be? A fracture until proven otherwise. That's what you have to say. If you tap on somebody's bone over a growth plate and they start freaking out, it is a fracture until proven otherwise. That's what I dictate. I say literally, I spoke with the patient and his family about his injury. Due to the fact that he has tenderness palpation over an open growth plate, that is a fracture until proven otherwise, and I'm going to protect it like that until I can prove it is not, either by radiology or time. This one would be a 1. Anybody? So this one's hard. This one's a trick one. So look, 1, 2, 3. 3-part fracture, right? Okay. So once again, treatment 1 part can treat it conservatively. You put them in a sling and you leave them there. The actual weight of their own arm pulling down on it in a sling will keep that distracted enough to kind of keep that in place. So unless they fall again or have somebody twist their arm, most of the time they do okay. 2-part, button. 2-part or more need ORIF. Does anybody know what ORIF stands for? Open reduction internal fixation. So literally we open it, cut the skin open, internally reduce it, or fix and then fixate it. Acute management, mobilization with sling and pain control, complications, adhesive capsulitis. The hardest part about orthopedics is there's a fine line between keeping something still enough to heal and so still that they get stiff, because then when the fracture's healed, they'll go, yeah, my fracture feels wonderful, look how much I can raise my shoulder. And then you know you have a lot of work to do. Okay, so once again, mid-shaft humerus fractures, same mechanics of the above, usually a fall on an outstretched arm, or a lot of times, especially elderly people, when they fall, they'll do like this, and so it's just a direct blunt trauma. Now remember, with the proximal humerus fracture, you worry about your axillary nerve. Mid-shaft humerus fracture, you worry about your radial nerve, right? Okay? And so what would that, so if I came in and said, what's the palsy when the drunk people fall asleep on the Saturday night palsy, or Saturday night, what is it called? Yeah, Saturday night palsy. Actually, I've seen 2 of those since January. Yes. Yeah, and well, only one of them was drinking. The other one was a much worse story, so I'm going to leave that one out. So radial nerve palsy, decreased wrist, finger, and thumb extension, sensory loss at the dorsum of the hand. So once again, this is one of those things that you dictate. Whenever you see a proximal humerus fracture, you dictate that they can feel the side of their shoulder. Whenever they have a mid-shaft fracture of their humerus, you want to dictate that they can extend their fingers and feel the dorsum of their hand. 2 views, treatment initial with a coaptation splint, or what they call a Sarmiento splint. And a sling, depending on how bad it looks. Sometimes you can do it with a sling, but a lot of people feel better when you put them in a splint. ORIF, a plate versus a nail. So I'll show you this one. So there is one. So that's what I'm saying. You're going to have the sweetest little grandma who's 86 years old that was feeding her bird and tripped and has this. And her whole entire family is going to be in there. Her son, her daughter, all of her grandkids, her husband if he's still living, and maybe their priest. And you're going to have to tell them why that sharp, jagged bone right there is going to heal. But you know what? It will. It'll heal just fine, every time. So the reason that we say a plate versus a splint, you think I'm kidding, wait till you go in the smallest exam room you have and there's 65 people. And I usually say something smart like, is there anybody else we're missing here? Do we need to call anybody? Family dog? So once again, you can imagine if with this type of a fracture, this one would, actually this one didn't need anything, but these coaptation splints, or clamshells is another way they call them. So it literally has a middle part, or a medial part and a lateral part, and you put it on them like a clamshell, and you just tighten it down. So it just uses their musculature to push everything in, and then they just wear it for 6 to 8 weeks, and then you're good to go. Most of them. Clavicle fractures. Anybody got anything about humerus fractures so far? Okay, so if I have a proximal humerus fracture, the one thing I'm going to make sure that everybody knows was working was what? Mid-shaft fracture? Okay, good. So, okay, clavicles. Typically in young children, most common is the middle third, usually caused by a fall on their shoulder or some kind of a fight with their sibling. Examination, pain, swelling on the localized area, tinting of the skin, obviously shows a more significant displacement, hematoma formation, and all of these things. This is another one, so you can see this, right? Obviously, now he's not a kid, but you can see that that's pretty impressive. Now, even with that being like that, so of course it is displaced, but remember, tinting of the skin is, because remember, when usually you have a broken bone, that broken bone is not nice and smooth. It's kind of sharp and jagged. So like if it literally looks like if it keeps rubbing under the skin, it's going to eventually poke through. That to me is tinting of the skin. This is just elevation and separation there. Radiology, X-ray of the shoulder, should get shoulder to access for other injury, or assess for other injury. So a lot of times there's an old saying that says it's very hard to, going back to the separations, it's very hard to separate your shoulder and injure your shoulder at the same time from like a ligament or tendon or biceps or something like that. So with these you can still injure your shoulder. So what they're saying is whenever you get an x-ray of the clavicle, a lot of times people just kind of do a weird chest where you don't see all the shoulder. Make sure you also include their shoulder. You always want to see everything as much as possible so that there's no room for liability or just you not helping out the patient. Indications for emergent or ortho referral is tinting of the skin, where you literally think if you leave that and they go home, it's going to go through their skin, or an open fracture. So remember, if it's open, then you start worried about infections and osteomyelitis, things like that. So that's why I was saying don't use compound. Just say, hey, it's either open or closed whenever you call us. Middle third can be treated conservatively. Distal third need ortho eval and possible surgery. So now on this one, so let me tell you guys something. So up until about how old are you guys? I'm probably going to be sad, but how old are you? In your 20s, mostly? Okay. Only the good doctor and I are in our 30s, of course. So back in he and I's day, this would get nothing. This would get a sling and a slap on the wrist and probably a lollipop. See you back in 6 to 8 weeks, champ. You're going to be fine. Now with the new advent of these nice plating systems and things like that we have, because we got to remember before, most of our orthopedics plates were straight up and down. Now they make these that actually, because if you look at a collarbone from the top down, it almost looks like a little bit of an S or a lightning bolt. They actually have plates that contour that now. So this one in ours, oops, sorry, these are super sensitive, aren't they? Where are we at? Where are we at there? This in our clinic now, we would give you the option. Would you like to have this repaired or would you like to have that there? The reasoning is because if there is any room between those two bones, that means there's soft tissue usually in there. If there's soft tissue usually in there, that ain't healing. Now, will it be a big deal in the long run? No. They'll probably have a happy life and go do whatever they want. But if there's a possibility that there's soft tissue between those two bony edges, so if this bone, like if we could literally see this bone was laying on this bone like this, even though it's 100% translated, it's going to heal all day long. They'll have a big bump on their shoulder from now on. But this one actually has a possibility of not healing. But once again, that goes back to what I said before. Even with something that obvious, I still give them the option. And you'd be shocked how many people say, no, man, I really don't like surgery. I'm just going to leave it like it is. I'm cool if I have a bump on my shoulder. Or if that ever goes on to, do you guys know the difference between the unions? So you have a union, which means everything's fine and straight. You have a malunion, which means it healed, but it healed in a bad position. You have a non-union, which means the two bones didn't ever try to heal. And then you can have something called an incomplete or a delayed union. That's usually on your diabetics and things like that. So once again, this would probably go on to be a non-union, but the question is it going to be an asymptomatic non-union? That doesn't bug me, and I don't want to have a big scar. Okay, sure. All right, so now onto the rotator cuff. Everybody cool with all the stuff we've covered so far? Yes, ma'am.
So do clavicle fractures like that predispose to shoulder instability?
I would say no to that. The book answer is probably maybe, but I can't remember the last time some kid had a collarbone fracture and came back going, "You son of a, you told me I'd be fine and now my shoulder's falling out of socket." I don't remember anything like that, but you have to remember, and that's a great question. The reason that she asked that is because remember, your shoulder is called your shoulder girdle. It literally sits on the side of your body. It'll go through your clavicle, your humerus, and your scapula, and a ton of muscle. So remember, it's all a fine balance when we start talking about these shoulder things. I know you guys have heard a lot of this stuff already, but it's pretty important to understand that because when we start getting into things, and I don't know if I have in this talk, but things like scapular dyskinesis and things like that, it's all about the balance because if you don't get it balanced, people are still miserable even after surgery. So rotator cuff tendonitis, significant source of morbidity among manual laborers and athletes. So this is another trick, and write this one down because it actually works. If somebody comes into our office over the age of 40 with any kind of an injury and trouble sleeping and doing things over their head, it's a rotator cuff tear until proven otherwise. Once again, anybody over the age of 40, and I mean 39-year-olds, we'll let them in too, but close to that. But with trouble sleeping, if they go, "Man, I don't know what I did. I was playing racquetball with my buddy and now I can't sleep on my right side. I'm always a right sleeper and now I'm not getting any sleep and I can't comb my hair anymore." Women, it's always the same thing. I can't undo my bra. Every time. This gets everybody. Guys can't put their hands in their back pockets like this. It's the overhead activity. You can't sleep on it. And somebody over 40, you're already thinking rotator cuff repair. Overhead activities such as swimming, tennis, baseball, softball, weightlifting, and all that stuff. We see a lot of people like me who are 42 next week and still trying to do this stuff. That's kind of the people that you see. You guys know all of these, right? So by far, supraspinatus. I can't remember the last time that I've seen Terry's Minor on an MRI, and we order probably 10 to 15 MRIs a day. Infraspinatus, you don't do anything about that one anyway. So subscapularis by far is the most commonly injured rotator cuff tendon. Subscapularis is the second most common, but they're different. Here's why. Once again, this is a book nerd thing, but like I said, since you guys have already been through the whole upper extremity, I'm going to give you the nerdy points. Whenever your rotator cuff, when your supraspinatus, remember, it sits on top of your humeral head like that. Remember on the bones, whenever you're looking at them, like on the skeleton, the proximal humerus, it has the round part, and then there's a little flat part before you get to your tuberosities. That's called the footprint. It's flat because that's where your rotator cuff attaches. So when a supraspinatus usually tears, it usually does this. It pulls off, right? Because it's, has anybody ever been playing tug of war and the other side lets go to be jerks and everybody falls? So think about it. So if I'm pulling my hardest as the muscle belly right here and that tendon lets go, I'm going to go where? That way. So that's why you have to see how much retraction there is. A subscapularis tendon. So what does the subscapularis do? It internally rotates your shoulder, right? So it hits the tennis ball, it slams the car door, whatever. Those tendons tear like this. They don't pull off, they split. So whenever we fix those versus the supraspinatus tendons, has anybody ever worked on a farm and baled hay? That's exactly what we do. We bale the hay. We clamp them down like this. So if this is the split, you do this and that. And that's how you fix a subscapularis tendon. All right, so once again, she said you had heard all that, so she wanted me to bring up the fancy stuff, so I am. Examination, shoulder pain with overhead motions. Pain with abduction, 90 degrees and 90 degrees of internal rotation, internal rotation. So Neer's test, this one's easy. It's just you stand there and passively raise their arm up like this. I know Sally just went through this, but I'm going to go through it again. It is passive range of motion. You go up like that. Neer is looking for impingement, right? So if your coracoid, if your acromion is hooked like this, you got to remember, so if I'm facing the front, my rotator cuff's right here, and I raise my arm up to the front, it can pinch it, right? So has anybody ever heard of impingement syndrome? That's what a Neer test tests for. So they're bringing it up like this, and if my acromion is hooked down, as soon as my shoulder hits it, I'm going to go, ooh, I don't like that. She's even doing it back there. Good job. That's a great test. Hawking test. I always think of the easiest way to remember this because it looks like a bird. You literally put them like this, and for them, you do this. You're trying to parade that rotator cuff under that hooked acromion. Always hold on to their wrist. Some of our little ladies get excited, and I have had several of them hit themselves in the face and knock off their glasses. I'm not being mean, I'm just telling you that's what they do. So whenever I hold them, I will hold them at their wrist and their elbow and kind of go like that, because if not, they'll start getting crazy. The empty can test, this is the most specific. So whenever you do the empty can test, which is where you take their arm at so if this is 0 degrees, 90 degrees, 45 degrees, thumb down and I'm going to ask them to push up, right? And I push down. That isolates the supraspinatus tendon. What's the most commonly torn rotator cuff tendon? So that's your money test. That's the one that you have to dictate and you have to show them if it is or is not positive. And then the lift off or the belly press test, this is called the subscapularis. So we've already established that the subscapularis does internal rotation. Some people call it the Napoleon test because Napoleon always used to stand like this in all of his pictures. So what you'll do is you'll say, okay, I want you to push as hard as you can down on your stomach and I'm going to try to lift it off. And if they can't do that, if it's torn, it's going to just come off when you pull it. The lift off, that's a belly press. The lift off is, remember, internal rotation. This is what a lot of people get hung up on. This is external rotation. So is this. So is this, right? So anything that external rotates your arm, it doesn't matter what it is. So this is still internal rotation. So this is the lift-off test. If their rotator cuff tendon subscapularis is torn, they will not be able to lift their hand off of their back because it can't do the same thing as this, right? Everybody with me so far? We getting tired yet? You guys good? Okay. Special test, once again, Neer's test. He's standing behind him or her and lifting it up. You can put your hand on the scapula if you want to, just to give them reassurance. I think that's over. It's not necessary. So Neer's test is good. It's kind of vague. It's either you're going to go, oh, that hurts. Well, so does the rest of your shoulder. Hawkins-Kennedy test. See, even this person was fixing to hit himself in the face, so she grabbed his wrist. So that's how you do it. You kind of stabilize one, you do the other one, because if you don't, you let their wrist fly, it's going to get nuts. Once again, what they'll do is you're doing this right here, and it's parading that under that hooked acromion. Rotator cuff tendinitis. I didn't put this slide together, so I don't know why that's on there. Treatment, non-operative basic orthopedic care, steroid injections, and then physical therapy and occupational therapy. So the way that, once again, if you go back to my 5 golden rules of orthopedics, you're just going to walk through them, right? Most of the time, by the time somebody has seen us, they've already seen their primary care physician, may or may not already have x-rays, and sometimes had an MRI. So a lot of times we can skip step 1 and step 2, and sometimes step 3. So basically, the steroid injections, our rule is no more than 3 per year per lifetime. That's it. There are some doctors who subscribe to no more than 3 per year every single year for the rest of your life. I will never give you more than 3 shots into your right knee. I will never give you more than 3 shots into your right hip as far as intra-articularly, because remember, sometimes a good thing can be a bad thing. Steroid injections have been known to deteriorate good soft tissue, right? So if I keep giving them to you over and over again, sooner than later that can obviously cause deterioration of the good soft tissues who aren't even injured. And the other thing is too, is if I give you 3 steroid injections in 3-month intervals, that's 9 months that you're still hurting. If I haven't helped you feel better in 9 months, do you really think another steroid shot's going to help? No, we need to figure out what's going on and get it fixed. Physical therapy and occupational therapy, once again, underused. Don't just throw pain meds at people, which of course now is a huge thing. And that's kind of the nice thing, and I know you guys aren't out yet and you won't understand this yet, but a lot of times people get mad that we can't write for as many medicines. I swear when you get out, sometimes it's a blessing, because it's always the people who say they're not crazy and who say they're not drug seekers. And then you can literally just go, look, it's illegal, I can't do it. I'm sorry. You want some Tylenol 4 with codeine? You want some Ultracet or Ultram or Tylenol X? The place that law screwed me was because in surgical subspecialties, if I have somebody coming back after a week after a total knee replacement, Dr. Olson's out of town, it's kind of like, oh, hey, Tylenol 4 sound good? And they don't really think that's as fun. So once again, the thing about it is, and I'm going to go off script here for a second, our clinic has actually started to embrace more of everybody's heard of the biologics, right? Platelet-rich plasma, amniotic allograft, or amniotic fluid treatment, the stem cells and things like that. I'm a big fan of those. I think those are the real deal. We tend to stay, you know that old saying about PAs, I'm not a doctor, but I just play one on TV. We kind of think to both sides of the fence on this, because there is the Western medicine model, which is, here's your hypertension, here's your antihypertensive, and you don't have hypertension anymore. Well, yeah, you do. It's just covering it up, right? So there are some things in orthopedics that we have actually seen help people to where they don't have to have surgery, where they don't have to be on chronic pain management, where they don't have to do stuff like that. We offer, is anybody familiar with prolotherapy? Okay, who? What is it?
I mean, I've heard of it before.
No, you said you were familiar, so what is it?
I mean, I don't know.
You don't know?
No.
Okay. So obviously she's not familiar with it. So prolotherapy is where you inject dextrose, which is sugar, and sterile saline into someone's joint. It elicits a little bit of an irritant response to get your body to come take care of itself. We do them in 2-week intervals, no more than 3 to 5 shots. The thing that's hard about biological shots is they're freaking expensive. Your insurance company will not pay for one lick of them. The PRP shots, of course, we draw the blood out of the patient. We have a the spinner, I call it the spinner machine, centrifuge. Hey, once again, we're in orthopedics, so we got to dumb it down a little bit. We spin it and we put the rich plasma back into their body. That shot is one shot, and alone, out of your pocket's $400. The amniotic allograft is the time of C-section, and of course there's consent from at least the mom. They harvest the amniotic fluid, which is full of stem cells, interleukins, tissue growth factors, and stuff like that. Basically this holy soup of everything that's good in life. And we can inject that, and 2 cc's, everybody knows what that is, right? 2 cc's is $2,000 for one shot in a coin flip, whether it's going to help or not. I'm going to tell you it will later. And then the last one is the bone marrow aspirate complex, or stem cells. The problem with today, right now, and I'm going to, once again, not getting on a soapbox, there are a lot of things being sold on the market right now as stem cells. Amniotic allograft has stem cells in it, but guess what? They're all dead. Platelet-rich plasma, no stem cells. So that's why, if you've noticed, if you watch the news for long enough, there are a lot of clinics that used to do biological stem cell shots that are getting shut down because they were billing people $10,000 for shots for stem cells, and there were no stem cells that were alive in their shots. That's why all these people are getting shut down. So that's why whenever I educate our patients, we actually have a folder, and I'll say, look, these first 3 do not have any live stem cells. The only one that we can is called the bone marrow aspirate complex, and that's where we take you into surgery. Everybody knows where their ASIS, anterior superior iliac spine. We drill a hole in that. We harvest out your stem cells, spin it down, and inject that in there. Dr. Olson has now recently reduced that for the low price of $5 grand for one shot. So guess how many takers there are on that one? None. Guess how many takers there are on $2,000? We've done over 200 of them now. So it sounds like a lot of money, but if you're older and have a bad heart and can't go to surgery, if you're, I mean, I have seen it with my own eyeballs, and it's not just because, and I don't make another penny on it, or I'd be the best car salesman ever for that stuff. But I don't make one more penny whether we give them, and I've literally seen it heal a partially torn rotator cuff tendon. Rotator cuff tendons do not heal themselves. Also remember this, if somebody has a partially torn rotator cuff tendon, any of them, it will never, ever, ever heal itself on its own. You can get an MRI 30 years from now and it'll still look the same as it did that day or worse. They don't ever heal. But I have seen it do that, and I've also seen the first guy we ever gave it to was a doubles tennis player, is a 65-year-old, and his knee, you could not see between the upper and lower leg bones. There was literally one bone almost, and we injected him because he wanted to not have total knee replacement if he didn't have to, and we still haven't fixed his knee, and that was 3 years ago. So once again, are there success stories just like with any diet or P90X thing? Of course there are. Are there people who may not have thought it didn't help? But I'll tell you, out of the 200 that we've given, I would tell you that probably 180 would pay for the 2,000 again in half. And in fact, my wife has a, you guys have done spine already? So she has a grade 1 spondylolisthesis at L4, L5 with a severe disc bulge at L4, L5. So she has severe neuroforaminal narrowing on both sides, but more so on her right. She's actually a dance professor over at the dance school. And she just got cord blood injected into her L4, L5 disc, and amniotic allograft injected on both of her facets, one on the right, one on the left, the 5th of July. And she's already noticed a difference, and that's just been since the 5th of July. So it's the real deal. We won't get on a soapbox, but it's pretty cool. Rotator cuff tear, same, shoulder rotator cuff tear, same as previous. Oh, yeah, so if it's torn, if it's tendonitis, it's an irritation. If it's torn, that's where we're at there. It's separated from the tendon is separated from the bone. I don't know why it says muscle. MRI, that's your best friend in orthopedics. MRIs, CAT scans, don't overuse them, but don't be afraid to use them. We always tell people, we get it on all of my PA students that I have come through from last year's class, you get an MRI to confirm what you already know. You don't get an MRI to go, well, I don't know, let's just see what it is. You're proving it now. Mobilized for the first 6 weeks, that's what people hate and gripe about after surgery because it's a 6-month protocol. If the patient waits too long to have repair, there's a chance that the tendon can't be fixed. What happens is if you leave those tendons alone and they're floundering around in the sea and they can't grab onto something, they get fatty deposits in them. And so whenever you take them to surgery and you try to start sewing through those tendons to bring it back down to the bone, it's like sewing through hair. It won't hold on to anything. So usually I won't recommend somebody that waits longer than 6 months is pushing it. A year to a year and a half, you're crossing your fingers, in my opinion. Once again, 4 to 6 months of rehab, back to normal of 1 year. So of 1 year, I can call you and go, hey, do you want to go golfing, fishing, hunting, dancing, arm wrestling, whatever? And you'll go, yeah, I think I'm ready by now. But at 6 months, they're not even ready for that. Labral injuries, this is what we were talking about before. This is what you tear usually whenever you have your shoulder instability. Now this one's a picture of a slap tear, so I'll get through that. A labrum, obviously cartilaginous tissue around the edge of a glenoid. Remember a cadaveric anatomy, it feels kind of like a mushroom on a pizza, right? So, but it's a little bit thicker. So this is the other thing. Yes, kind of weird, mushroom on a pizza. I kid you not, whenever you start using things as analogies that people understand, it's money every time. If I just came in there and said, well, I'm sorry, it looks like your MRI says you have an anterior-inferior labral tear from 330 to 530. There's not a bony Bankart. It's just a Bankart at this point, and it also shows you have a little bit of splitting of your biceps. They're going to hear maybe bony and remember that, and then their dad will come back the next week going, my son said you had something wrong with his bone. So what you have to do is, they're not going to get it some of the time, right? So what I always try to do, because both my parents were school teachers, and I'm one of those have to read things 50 times before I get it. I wasn't blessed like just reading it once type deal. So I put things into ways that my brain will understand. I'm sure all of you read it once and understand. But so in fact, like for using a partial thickness rotator cuff tear, that's my peanut butter and jelly talk. For when people say, well, I think I'm pretty overweight, and I think if I just lost some weight, I'm going to not have arthritis anymore, I'll use the rocks in the back of a pickup truck with bald tires talk. Once again, people get what they can put their brain around. If you will make it, and I'm not saying dumb it down because that's insulting to the patient. I'm painting a picture in their head to where they go, you know what, I get that. Because remember, that's why I don't stand up, that's why I don't wear a white coat. My name's right here, and that's only because I think you have to by law or have your diploma hang up in your clinic. So remember that advice. You're not dumbing it down at all because that's insulting to the patient. All you're doing is that you're explaining it. It's kind of like whenever I go to the car mechanic, I don't know what the hell they're saying. I know how to put gas in it, right? Gas and air the tires up. That's about it. But when they start talking about flux capacitors and radiators, I'm like, oh, okay, whatever. Come on, that was Back to the Future, right? Somebody, flux capacitor. Okay. So slap lesion, superior labrum, anterior to posterior. That's easy because it's literally telling you where it tore. Superior labrum, it tore from the anterior to the posterior. When you get MRIs of the shoulder, remember that if this is a right shoulder, and it is because the bicep tendon is going out the top. Remember, biceps tendon, long head of the biceps attaches at 12 o'clock. When you get an MRI report, they will tell you the clocks that it is torn. If it's torn from 3 o'clock to 6 o'clock, that's an anterior and inferior. If they say it's torn from 10 to noon, that's a posterior superior labral tear. That's only for the right shoulder. Remember, for the left shoulder, you flip it. Now the 9 o'clock is anterior and the 3 o'clock is posterior, right? That makes sense? Everybody got me? Okay, good. So slap lesion, superior labrum, anterior to posterior, these are the first 4 types. This is a type 1 where there's a disruption between the actual anchor itself, but it's not torn off. Type 2, you can see that there is actually let go of the bicep tendons that attach to the labrum at 12 o'clock. Type 3, the labrum is attached to the glenoid, but the labrum is sloughed off. So think of this like a bucket handle meniscal tear. This will lock up your shoulder, right? Bucket handle meniscal tears, one of the only things that will lock up your knee or a big loose body. This will lock up your shoulder. And then type 4 means everything's messed up. Biceps tendon, labrum, capsule, everything. Shoulder labrum injury, apprehension test. So an apprehension test is whenever you take them like this, and I always say, hey, this is the last test of the day. And actually, whenever we're done, if you want, I'll actually show you my shoulder exam so you can see how I go through it and how smooth you can make it. So this is an apprehension test. Some people have them stand up, some people have them lay down. I try to, on your phys die stuff, whenever I was in school, they made us have this final examination, and they marked how many times that you made somebody sit down and stand back up, and, oh, I'm sorry, lay back down real fast, and oh, I'm sorry, stand back up. I just do my whole shoulder exam standing up. So what I do is I put them like this, and then you will passively external rotate their arm. Apprehension means they'll start going, whoa, hey, stop, 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 stop. They'll go, everybody goes up on their tippy toes for some reason. That's not going to stop it. But they'll go like this. So if they feel like their shoulder is going to go out the front, which is the most common, that's a positive apprehension test. This is a positive posterior apprehension test for a posterior shoulder dislocation. A jerk test, posterior, I don't recommend that. O'Brien's test for a slap tear. So there's a lot of stuff about O'Brien's. I think I may have one here. So this is what the book does. Read that for your test. In real life, this is mine. So whenever I do an empty can, right? So I have them push up against me. My O'Brien's is, I flip their palm up and I have them push up against me, right? Because you got to remember, if you think it's any of this stuff, what are you going to get? An MRI, right? So you don't have to nail it on that. But if you're out in rural America and they say, hey, I don't have an MRI close to me. So once again, the book test for an O'Brien's is that you take them at 9 degrees of abduction, thumb down, and you have them go 15 degrees across midline, and you have them push up. And then you have them turn their palm up, and you have them push up, right? And so obviously if the pain with internal rotation, if it hurts with internal rotation but decreases with external rotation when they turn their palm up, that's a scapular or a slap lesion. Remember, what is the slap lesion testing? What do you think about physics? If I'm pushing up, it's putting the force through here. It goes to my biceps. The biceps tendon attaches to the labrum, which makes the slap lesion. So if I'm doing this, right, it's going to hurt. Treatment non-operative basic orthopedic with immobilization in the gunslinger position, which is here, or the robot, whichever one you want. Operative treatment if it fails conservative measures, 4 to 6 months of rehab, same with the rotator cuff. Patient can run for 4 months and swim for 6 months. That's the same thing on rotator cuff and labrum. And you can't throw, if it's your dominant arm, for 9 months on a labral tear, especially an anterior one. No contact sports on the dominant arm or overhead throwing for 9 months. Anterior apprehension test, once again, I've seen some people do it where they lay people down on a table and they scoot them over to where their shoulders hanging off, and you can do the same thing. But to me, once again, having them stand up and sit down a bunch is kind of annoying to them, and it's a waste of time. Shoulder impingement syndrome, impingement, combination of shoulder symptoms that cause limited range of motion and pain. Positive Neers and Hawkins. We've already gone through that. Neers, you just raise them up. If their acromion's hooked, it'll impinge on their rotator cuff. Same thing with Hawkins, but guard their wrist and their faces. Pain with range of motion above the head and shoulder, abduction above 90 degrees. Conservative treatments for 4 to 6 months. Operative is failed conservative subacromial decompression. I will tell you this, I can't remember the last time that we just did a subacromial decompression on someone for an impingement syndrome. Subacromial decompression is what I like to call the blue plate special. That's usually whenever you have a rotator cuff that we had to fix, usually either a biceps tendon or a labrum, and a subacromial decompression is kind of like coffee at the end of the meal. That just comes along with it. We do that on, if we take you to surgery, we're doing a subacromial decompression 99% of the time. Adhesive capsulitis. And do I need to go backwards anywhere? Is everybody cool so far? Okay, please tell me. I don't want you guys to not understand. Adhesive capsulitis, gradual development of global limitation. Isn't that sound fun? Global limitation of active and passive range of motion. Adhesive capsulitis is easy. If can I borrow you again, please? We'll call you Vanna for right now. Okay, so if she comes in and she's had, can't lift my arm above my head, stuff like this. This is how you will ace adhesive capsulitis every single time. So raise your shoulder up. Don't go all the way up because that's not adhesive. Go to 90. No, straight arm, right there. So she can go to about 90, right? So this is as high as she can go. Because this is what happens, is a lot of times physical therapists will send you over people for frozen shoulders, primary care doctors will send you over, and they'll go, oh my gosh, I've got the worst frozen shoulder ever, and I'll go, okay, let me just check it. Okay, that's not frozen. So frozen shoulders is if she can only go to 90, I let her relax, and I can only take her to 90. Now, sometimes they will say, oh, that hurts, don't go any higher. That's not frozen. Frozen's whenever I'm pushing up pretty firmly, and if what she can do at 90 and what I can do at 90 is the same thing, now you're concerned about it. Thank you once again. You did great. So once again, that's an easy way to ace the adhesive capsulitis is if passive and active range of motion are equal. Because if they say I've got a frozen shoulder and I take their arm all the way up, it ain't frozen. I just made it passively go up above your head. This one is one of the most common in men, 50, 60 years old, women with diabetes. Diabetic women, those are your two key words. People with diabetes that are out of control, and women love to get stiff after shoulder injuries and after shoulder, most specifically after shoulder surgeries. That's why we start formal physical therapy after a rotator cuff repair at 1 week after their surgery. They're already in therapy with passive range of motion only. Treatment's conservative with PT. We're going to give them a bit. Also, this is a good one because when people freak out about adhesive capsulitis, we do not worry about it adhesive capsulized until 4 months after your surgery. If you are stiff in the first 4 months, that's normal because we just cut you open and fix stuff. If it is after 4 months and only at 4 months, that's when we start to go, hey, you know what? We got to do something here. There will also be, so you have to be at least 4 months, and you also have to have no improvement in regards to range of motion, both actively and passively, between months. So if you see me at 4 months, and I go, man, she's got like forward flexion to 120, abductions to about 110, and you come back next month and you've got forward flexion to 120 and abduction to 110 after doing therapy for a month, you should always increase, okay? Surgical arthroscopy with capsular release, this is what we do. Manipulation under anesthesia is kind of barbaric. Has anybody ever seen or felt one of these or been through one of these? So basically what you do is, are you still back there? Is that Sally back there? Sally's seen it, but that's not fair, you're a professor. I'm just going to say that now because you're a professor now.
And you hear it.
Yes, you can. So what they do is they put you in usually a beach chair position or lay down. They get you kind of loopy with gas, and then Dr. Olson goes like this, and then he does like this, and then he does like this, and then he does like this, and you literally hear it tearing like Velcro. Wasn't that what you'd say, Sally?
Yeah.
Like a Velcro-ish, and sometimes it'll pop, sometimes it'll tear. That one, the reason that Dr. Olson doesn't do this one as much is because there's no, it's going to sound bad because it's going to sound like I'm saying you shouldn't do it the other way. This way is fine. He likes, there's no visualization of it. You just feel something tearing. How much did I tear? What tore? Is it going to be okay now? Did I tear enough? We like to do this surgical arthroscopy with capsule release because then you're inside this big capsule looking up at it like a water balloon, and then you make little perforations like an accordion and it can spread out. And then you can control how much you release. Oh wow, that's it. Questions or concerns? Anything that I did not cover? Anything that you guys would like to know? Anything that I went too fast over? And it won't go backwards so tough. Seriously, any questions or concerns about anything? Yes?
Could you maybe go over again the labrum tears?
Yes? Okay, what do you want to talk about? Well, you have to come up here and make this thing work then. I don't know. Does anybody know how to go backwards? Miss Sally or Professor Sally?
It's on the way.
Okay. So, what do you want to talk about?
Just like how you were describing the clock.
Okay, so look at it this way. So, and this is the best way to think about it. If I'm standing here like this is my right shoulder, obviously. If you pull my arm off and you're looking right into labrum, and this is, once again, this is how I describe it to our patients, right? Because if not, they don't get the whole this thing. So if I say, look, if this is my shoulder and you pull my arm off, it's no longer there. Here's my biceps tendon coming in. Well, it wouldn't be there if my arm was off. So this is 12, this is 3, this is 6, and this is 9 o'clock on a right shoulder. So imagine it like this. So if I'm a clock right here, 12, 3, 6, 9, right? So now let's say I do this. Well, now 12, 3, 6, 9. So is 3 o'clock still anterior? No. So that's what I'm saying, and that's only from an MRI standpoint. You do not care about the clock until you get to the MRI, because what I want you to do, if you go into orthopedics, is you're going to have to be able to describe to the patient where it is. You're torn anterior, posterior, or I'm sorry, anterior, inferior. You're torn posterior, superior. You're torn the whole way around. That doesn't happen very often, but I've seen it twice. It goes all the way around. Oh, thank you. So that's the way that's only for MRIs and description of that. Because once again, I promise you, and this is another little caveat that you can take home. I know that I sound like a fortune cookie a lot, but I'm not kidding. The more that you can educate your patients in the room, the less phone calls you'll have and the less misunderstanding you have. Has anybody ever heard the old saying, we fear what we don't understand? So anytime I go to do anything else besides orthopedic at the doctor's office, you get kind of freaked out, right? This guy's saying all these big words, his beard getting hairy, and he's yanking on my arm, and he just read me this MRI report. And you got to remember, they're only going to catch 75% of what you say, no matter who they are, right? 75%. So the thing about it is the more that you can sit down with them, I'll draw ugly pictures, I'll show them stuff on our boards, I'll do whatever it takes to get them to understand. And at the end of it, I'll go, do you understand everything that I just told you? And if they say no, I'll go back again. Yes, you will run behind because of that, and your nurses will hate you, but at the same time, you're the one getting the phone calls at night, not them. And also, if you'll help your patient understand what's going on with their body, they'll walk out there going, man, it's a bunch of big words, but I at least understand what's wrong. I understand why they don't have to fix it. I understand why they have to fix it. I have to understand why they need to do surgery on me when I really don't want to do surgery anyway. So those are the biggest things, you guys, is just educate, 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 and then, but don't over-educate, because you can tell when they start getting bored, like her, she's putting books in her bag and she doesn't want to learn anymore. But stuff like that, right? So what other questions do you guys have? I'm just teasing, of course.
I would add to what you're saying. I think a lot of successful surgeries are matching up expectations.
Yeah,
So if you have if your patient or you have expectations prior to surgery that are completely unequal,
right.
there's no way you're going to be successful with that surgery. You know, just like we talked about, you don't do knee replacements to improve your knee motion. You do them to get rid of pain. You know, you're not going to have a normal knee. You're going to have a mechanical knee. It's not going to feel like a normal knee that God gave you. Things like that.
Yeah, can't go skiing.
You have to match the expectations of it.
Especially with shoulders, total shoulders,
Yeah.
we do total shoulder replacements, and those are always, because people always think I'm going to get everything back. With shoulders, you just don't want to hurt. If they can raise their arm to 90 degrees, I'm tickled pink. If they can get higher than that, I give them a hug. But other than that, you have to, once again, it's about managing expectations, because if the patient comes in with high expectations, and doesn't get what they thought, that's where your lack of educating them on this is what's probably going to happen after surgery. If you do that, if you educate them, you go, look, there's a chance that you may not regain all of your full range of motion, there's a chance that you may not regain all of your strength, but you're going to have better pain after this. As long as they have less pain, bingo, we did it. We did what we said we would do. If you get stuff on top of that, everybody's super excited. But she's exactly right. You have to let them know what they can expect, and I'll even go over the entire post-operative protocol on the date that we sign them up for surgery, just so that I can say you heard it before surgery. Olson tells them at surgery, and I tell them the first visit that we see them, and I even have it typed out so they've heard 4 times what we're going to do with them after surgery by the first week after their surgery. If they don't get it by then, it's kind of like what they say, we have to tell somebody we're a PA and not a doctor 3 times, and if they don't get it, that's it.
Right.
I mean, that's really a rule. Like, you have to inform, like, so you have these old ladies that go, okay, doctor, and I'll say, no, I'm Travis, I'm not Dr. Olson, he's tall and bald. And they'll say, no, okay, doc, I get it. Well, there's 2, and it's kind of like Beetlejuice, right? I mean, 3 times. And so after the 3rd, I'm like, they're not getting it. I'm not telling you anymore. It's written right here.
There is a bit of sexism with that, too. He'll get called doctor and I'll get called nurse.
Leave it to Tally to bring the whole Me Too.
But it's true, you'll see
it. Is true. It is true on that. Same thing with nurses too.
Yeah, same
Yeah. What other questions about orthopedics do you guys have? Because I think I'm teaching you knees on Monday. Any other questions? So seriously, shoulders are okay. So let's make it last one, and then I'll show you guys my exam with Vanna if she'll let me. Shoulders are very, very difficult to diagnose. Knees are easy. You've got 2 meniscus, 4 ligaments, and 2 meniscus, 4 ligaments, and then 2 or 3 bones, right? So that's kind of easy. It goes this way, or not. Shoulders are, I always keep my cards very close to my chest on shoulders. I'll say what I think it is. That's another rule, you guys. Don't ever tell them what it is before you get the MRI, because if you're wrong, they don't trust you anymore. So what I'll say is, you know what, I'm highly suspicious based on your physical examination of maybe your rotator cuff tear, maybe a little bit of AC joint arthritis based on the x-rays alone, but let's go get this MRI and see what it says. I know they've torn their rotator cuff because they can't even hold their arm up like this, but at the same time, I learned that like my 2nd year on the job, is don't tell them what it is until you, if you're going to get further studies, because if not, they won't trust you. Can I borrow you for a second? Okay. So this is my shoulder exam when somebody comes in the room, okay? And you'll see where all of this ties all of this up. Did everybody get this though? I didn't go too fast, you guys are good. Okay, so this is my shoulder exam. So the cool thing about this, if you'll turn this way, so I'm going to obviously examine this shoulder. So first thing I touch is their AC joint, and this is kind of a cool trick, and I haven't trademarked it yet, but if you steal it, I'm going to be mad. So index finger, AC joint. Guess where this lands? Which one? The short head. No, don't say long, it's short. So this is the coracoid. That's where the short head of your biceps attaches. Now watch. What's right there? The long head of your biceps. So you just knocked 3 things out. 1, 2, 3. That fast, right? Does my AC joint hurt? Does the short head of my biceps hurt? Does the long head? Ooh, that's kind of tight, isn't it? Yeah. Okay. So it's ticklish. Okay. So there's that first 3 things, and you know you have to examine and all that, auscultate, but whatever. And then you come up. So this is the Neers test. So she's passively. You can actually. So Neers. Hawkins, right? But see how easy it is? It doesn't take much. Crossover, what's this for? AC what? Okay, what's this for? Impingement, and what's this for? Impingement. This is still impinging, because remember, turn. If my acromion is hooked down, and I'm bringing their shoulder up, and I'm doing this, it's doing this. So that's an impingement test. Okay, turn and face me if you will. Okay, so no numbness and tingling in your fingers, right? Okay, take both arms straight out in front of you, and like Supergirl, go all the way up in there as high as you can go. Forward flexion, right? Okay, back down. That's a sound effects. Sweet. Okay, so then act like you're doing a slow jumping jack. Come up. Always tell them not to move their legs because most of them will do their legs too. So slow jumping jack. Put your arms to your side for me. Roll them out. What does that do? What does this? Well, I know it's external. What does it? What does this? What muscle? What rotator cuff? Well, okay, so let's make it easy. This does what? What only thing does this? Oh my God. What did I tell you the only thing an empty can test is? What does this do? Supraspinatus. What if subscapularis does this? There's only two left. And? Gosh. All right, so good. So external rotation. Now do this for me. Internal rotation. This one's hard for everybody, by the way. Okay, so now we've just tested AC joint, short head of the biceps, long head of the biceps, near for impingement, Hawkins for impingement, crossover for AC joint. We just now have her full range, or all of her range of motions, right? Put them right here for me again, and then this time you're going to push out against me, which uses what two rotator cuff tendons? Oh, we just did. I know. Teres minor, push in. So there's our subscapularis, right? Internal rotation, palms up, push up. What's that? Oh, come on. Seriously, what pushes up? What does this? Biceps, okay. Push down. You're all scared. Okay, push down. So this is what? Such biceps. Bring it out like this, thumbs down. You push up towards the sky. Okay, turn your palms up for me, please. Sure. Good. Now face that wall over there for me if you don't mind. And then, just relax on this one. I've been doing everything, just let me hold you. There's anterior apprehension, posterior apprehension. That's it, whole shoulder exam. So let's do this again real time, ready? Okay, so if I'm just meeting her, hey, my name's Travis, I'm PO with Dr. Olson, Olson Orthopedics. AC joint, short head of the biceps, long head of the biceps. Okay, I'm gonna just bar your shoulder, just relax for me here. Tell me if anything bothers you, okay? Okay, so turn and face me, take both arms, go all the way up in there like a Supergirl, back down, act like you're doing a slow jumping jack. Put them right like this for me. Keep your arms there and roll them out. Walk them up your back for me, please. Put them out here in front of you. You're going to push out against my hands, in towards you, up towards the sky, and then down towards the ground. Let me borrow your arm for 1 second. Thumb down. You're going to push up, and I'm not going to let you. Turn your palms up. Okay, good. If you'll face that wall right there for me and just relax. That's it, right? It took me 17 years to get to that, though. Like the first 15 years I sucked, but this is just going on. But that's the point of it, and this is another thing. You're good. Thank you once again. She was amazing. The thing about it is that's my way. That's the way that I learned it. That's the way that I feel comfortable. That's the flow that I like to use. It doesn't mean that's what your way is. And believe me, after you start doing this stuff, and I'll show you guys with the knee too, you do it over and over again, and kind of in today's medical society, we're not afforded a lot of time in the room with the patients if you're going to try to be productive and make money for your clinic. So you don't get to take a whole lot of time, because I am a talker, as you guys have probably noticed. So I spend more time educating than I do on physical exam, which means I've got to do that a little bit faster. Not skipping over stuff, you just have to get fluid at it. And I'm going to tell you this, because I remember whenever I was in you guys' shoes 17 years ago, I kept thinking, wow, how long will it take for me to get that good? 3 years. It was 3 years before I walked into a clinic without looking at the schedule the night before, going, oh my God, I hope I don't see something hard tomorrow, and all that stuff, right? So I would literally go through every patient. What am I seeing them for? And I would educate myself just so that I wouldn't look silly. Because you learn all this book stuff, and then you get out, and it's kind of like, well, your insurance company doesn't cover that, or this doesn't work that way, or that doesn't work that way. So once again, it's not my test, it's not my rhythm. That's what I like to do. If you watch Dr. Olson's, his is totally different than mine. So what you need to do is you just need to find a friend and just go through that stuff and through that stuff and through that stuff. And then also remember, it won't be that fast in the clinic because something's going to hurt. Well, whenever it hurts, you kind of got to go, okay, well now tell me exactly how it is. And just to leave you on a funny story with the apprehension test, I used to work for a doctor named Dr. Cruz. Have you ever heard of Dr. Cruz, Tony Cruz? Yeah, like the grand poobah of sports medicine in Oklahoma City. And I had this lady that had come in, or a young woman, actually, she's probably 19 or 20, sitting on the bed. And I swear to God, it's I thought he was a professional wrestler. It was the biggest guy that I've ever seen in my life. So I'm doing her test and all that stuff, and I said, okay, on this apprehension one, we're going to kind of test for shoulder instability, but don't worry, if it pops out, I'll put it back in. It popped out. And he stands up, and I went, I'm fixing to die unless I can get this in real fast. So be careful what you say, because you can really dislocate it like that. But that's the whole thing about it is have fun with your patients, establish a relationship with them. Because, you know, there's a guy named Daniel, I think it's Daniel Pink, wrote a book called Drive. Have you guys ever read that? Anybody? I know you guys are reading all textbooks and stuff. But whenever they found out that patients had a better rapport with their professional, doctor, PA, nurse practitioner, whoever, they're also less likely to sue you because they trust you. I have a feeling that Travis had my best interest in mind. I realize that he probably didn't see that very small stress fracture on an x-ray, but I'm sure he didn't mean to do that, right? This is Travis, this is my guy, right? So once again, take a little bit of extra time. I know that I'm all Oprah on you right now, but seriously, take time and get to know your patients. Find a commonality with them. Talk with them about the weather, talk with them about their grandkids, but be careful with that one because they'll start bringing out their iPhone that they don't know how to work, and then they'll be like, can you know my passcode and stuff like that. So if you guys need anything, let me know. Hopefully I haven't gone over too far. Actually, I'm an hour early, you guys should. All right, I'll see you guys Monday.